Welcome to the session titled The Role of Partnerships in the Integration of Intersectoral Data, Inter-Country Perspectives. This is an on-demand session for the International Population Data Linkage Network Conference 2020. Hello, my name is Sujitha Ratnasingham. I'm the Director of Strategic Partnerships at ICES, a research institute in the province of Ontario in Canada. I have a strong interest in the integration of the social determinants of health into health research. Through my work, I've had the opportunity to see the importance of partnership to this work. I am honored to be presenting with my esteemed colleagues. From Australia, Ximena Camacho from New South Wales Department of Premier and Cabinet and the University of Melbourne. From Canada, Brent Diverty from the Canadian Institute for Health Information. Dr. Ted McDonald from the New Brunswick Institute for Research, Data and Training at the University of New Brunswick, and Nicole Yade from ICES and Health Data Research Network, Canada. The objective of this session is to explore the role of partnerships throughout the data integration lifecycle from the vantage point of different jurisdictions. Presenters will discuss the barriers, mitigation strategies, and successes they have experienced across different jurisdictions on this topic. We felt it would be helpful to provide you with a high-level description of each country. We hope this gives you some insight into the historical contexts that have influenced the landscape of privacy legislation, health responsibilities, and barriers to flow of data across sectors and between jurisdictions within each country. Starting with Australia, with a population of 25.6 million people, it's a federated country with 6 states and 2 mainland territories. The federal, state, territorial, and local governments share responsibility for the health system and its delivery. The system has public and private components, and health data responsibility is shared by state territorial organizations, the Commonwealth Department of Health, the Australian Bureau of Statistics, and the Australian Institute of Health and Welfare, which is a national agency for information and statistics. Statistics developed by this organization are often used to inform policy decisions on health, community services, and housing. Under Australia's constitution, health and welfare services are primarily delivered by the states and territories, who are also mainly responsible for the collection of statistics on these services. Next, we have Canada, with a population of 38 million people. It is a federated country with 10 provinces and 3 territories. The federal and provincial and territorial governments share responsibility for running the health system. This results in 14 individual health systems. The federal government's role is primarily to fund the system with additional responsibilities that are specific to veterans and Indigenous peoples. The provincial and territorial governments have a focus on delivering care, and about 70% of the healthcare system is public. Health data is a shared responsibility across the provincial territorial organizations and pan-Canadian organizations. Pan-Canadian health data is a shared responsibility between the Canadian Institute for Health Information, Statistics Canada, Health Canada, and the Public Health Agency of Canada. Each organization has a defined role within the health ecosystem. So as our first question, what barriers has your country experienced to fully integrating health and social data?
So I'm Ximena from the New South Wales Department of Premier and Cabinet and University of Melbourne. So as you mentioned, Sujitha, Australia has a federated healthcare system. So even just within that system, there are silos in the data that's collected. Each has its own separate legislation that governs that collection, and then by extension governs the ability to share or combine that data. And then on top of that, there are some long-standing cultural barriers around data sharing. And there's often not a huge desire for data custodians to share and link their data. When it comes to social services data, then we have the added complexity of additional players like other government agencies and the legal and privacy issues around data sharing that those bring. The one other point that I'll add here is that some of the service delivery agencies in the social services space are quite small. So for example, they might be community-based organizations, and they don't always have a huge amount of resources that they can invest in maintaining and preparing data for linkage. So even if the desire to share is there, there can be a bit of a technical or capacity barrier to actually make it happen.
So speaking for Canada, Ted McDonald, and in terms of barriers, I think one of the main barriers arises, you can think of it in the context of a series of nesting Russian dolls, and it's about silos. With healthcare, education, and social assistance, the jurisdiction of the provinces, we have 13 separate systems that are developed independently, so they have separate legislation. There's no common data standards. There's no consistency in what is collected. There's no consistent approach to data access for research. And so even if there is a will to do so, the opportunities for sharing person-level data between provinces is almost impossible. Within provinces, silos and how the departments or ministries are organized preclude data sharing because legislation is often specific to data and programs within departments. So it does not allow or anticipate data sharing except in very specific prescribed reasons such as integrated service delivery. There's also political risk and risk aversion that arises from a sense of loss of control and competition for provincial budgets. So for example, in New Brunswick, data on long-term care and nursing homes is the jurisdiction of one department, and data on hospital and certain other home care programs are the jurisdiction of another department, and those departments do not share data on individuals. Even within departments or ministries, there are restrictions on data sharing, again, because data access is prescribed in legislation to be shared only for certain purposes. So in addition to the silos that we are all facing within provinces and within departments and ministries, there is a universal barrier arising from legacy data systems where data collection is traditionally it's about monitoring the provision of services. So the systems have been designed to ensure that physicians are being paid, for example. But there's no planning or building into the system about the need to evaluate the impact of those services. So even information collection itself is limited in these legacy systems. For example, there's a dearth of indicators identifying vulnerable populations. So it's very difficult to find in provincial data systems indicators for Indigenous Canadians or indicators for gender beyond the traditional male-female or for ethnicity. And even when there's a will to change, the resource requirements in terms of people, money, and time often preclude progress in doing so, since most of the focus is on the day-to-day operation of the departments. This is especially true in smaller departments, smaller provinces such as New Brunswick and territories, but it's also a problem in larger ones. Inevitably, changing legislation, which is what's required to access data more widely, is politically very difficult to do so.
Thank you for sharing some of the barriers that you've experienced in your respective jurisdictions. Can you speak to some of the mitigation strategies that you've employed, including partnerships, in order to integrate health and social data?
One of the things that I'm currently working on is on supporting the establishment of the National Disability Data Asset, which is a project that aims to harness the power of linked data to provide people with disability with the insights that they need to choose the services and supports that lead to the best outcomes, and at the same time provide governments with the information that they need to provide the necessary services to support those outcome pathways. This is a national initiative that involves 9 partners across the Commonwealth, the states, and the National Disability Insurance Agency, and it's been endorsed at the ministerial level by the Australian Data and Digital Council. And it's going to bring together data from across many different sectors, including health, justice, housing, education, disability services, and so on. So right now we're about a third of the way through an 18-month pilot phase, but there are some key factors that I think have helped to really progress this work so far. So the first of them that I'd like to highlight is senior level engagement and a real commitment at that high level to enable the work and unblock barriers. The second is that this work has been resourced, so people have dedicated time to help to work through the problems and support the different activities, and no one's trying to do this on top of the million other things that they also need to get done. And the third is getting all of the key stakeholders around the table so that everyone is going along on the journey, because I think overcoming particularly some of the more long-standing cultural issues around cross-jurisdictional data sharing are as much about change management as they are about solving technical or legal hurdles.
I'm Brent from the Canadian Institute for Health Information, providing the Canada perspective. 3 mitigation strategies come to mind that have enabled integration of health and social data. The first is organizational structures. Effectively, these are partnerships offering funding and mechanisms for consistent data collection, data standards, and access to data for researchers and policymakers. Examples include my organization, the Canadian Institute for Health Information, which is a partnership of the federal, provincial, and territorial governments, funded by them, but independent from government. The Canadian Research Data Centre Network, a data platform partnership between Statistics Canada, universities across the country, and the research funding organizations in Canada. And finally, Health Data Research Network Canada, or HDRN, which is a partnership of provincial and territorial health data centers, Statistics Canada, and CIHI. The second mitigation strategy is purposeful partnerships with governments, privacy commissioners, and the public in the country. These are key to understand and influence the legislative and privacy landscape, and also to ensure there is social license for use of the data across the country. The third mitigation strategy is learning from other jurisdictions. In Canada, this enabled provincial and provinces and territories and the country as a whole to learn from the barriers, mitigation strategies, and successes of others. In Canada in particular, we look to the UK, to Australia, and Nordic countries for examples and inspiration. And Canada has followed with interest the data linkage capabilities in Australia and the SAIL data bank in Wales. Underlying all of these mitigation strategies is transparency, a critical aspect of ensuring trust and progress.
Thank you for sharing some of the mitigation strategies that you have employed in order to overcome the barriers. Now, what are some successes that your country has had in integrating health and social data through partnerships?
There are a lot of different initiatives that have been successful in recent years, but from those that I'm closest to, I think the National Disability Asset, even though it's still in the early stages, is turning into a success story. So we've established a national team with representatives from every partner, and together we've really created a productive and collaborative environment that has allowed us to make a huge amount of progress in a really short amount of time. And I think this is a really strong demonstration of how these kinds of partnerships can work really well in practice, especially those that have senior champions, and lead to some really great outcomes. Obviously, the longer term successes remain to be seen, but we've laid the groundwork to collectively work through some of the barriers around interjurisdictional data sharing at more of a system level. One of the other major initiatives that's going on at the moment in Australia is work underway by the Office of the National Data Commissioner to introduce some new legislation to streamline data accessibility, data sharing, and use at the federal level. Throughout this whole process, the Office of the National Data Commissioner has really sought quite a lot of input from a number of different stakeholder groups, including data custodians, privacy bodies, and the research community, and used it to shape the proposed bill. So although it's not really a true partnership per se, it is a consultative process, and it's brought people along on the journey with an aim to create a product that works for as many people as possible, or as well as a single piece of legislation can achieve that. I also think it's worth mentioning that the COVID-19 situation has shed a lot of light on why this kind of infrastructure and integrated data assets are so critical. And at least in Australia, there are things that have been accomplished in the past few months that people have been trying to get over the line for years. So it started to create the sort of environment that is more conducive to creating these kinds of linkages and supporting cross-agency and cross-departmental initiatives.
Hi, my name is Nicole Yade, and I'll be speaking about the Canadian perspective, and specifically about Health Data Research Network Canada, or HDRN Canada. HDRN is an inter-organizational partnership across Canada, which has internal network member partnerships in the provinces and territories, and external partnerships that each of our centers have with data holding organizations and researchers that both exist in parallel and are mutually reinforcing. specific to the internal partnerships between our member organizations, we have decades of experience as responsible stewards of health and health-related data and have been working together for years across jurisdictions. Because of these strong relationships, we can play a role in leveling up amongst data centers and learning from successes and challenges, including overcoming legislative and trust barriers to using non-health data. Through this experience, we can do things such as facilitating agreements with federal agencies and the provinces and territories, leveraging that expertise that some of our centers have. When it comes to external partnerships, the HDRN Canada member organizations bring with them their established relationships, including with local ministries of health and other ministries and local data providers that other member organizations can then learn from. For example, in Ontario, they have passed legislation to enable sharing of data across sectors. ICES has been given the opportunity to become the only organization outside of government to be able to work with the intersectoral data due to support by key ministries with whom ICES has built partnerships through collaborative projects. Some examples of these projects include integration of immigration data and health data on a report entitled COVID-19 in Immigrants, Refugees, and Other Newcomers in Ontario, and the integration of social assistance and health data using administrative health data to identify individuals that have intellectual and developmental disabilities. The Data Access Support Hub, or DASH, which you can hear more about at other related sessions that we will be showing on our last slide, is an external facing platform that demonstrates what's possible through the interorganizational partnerships that exist because of HDRN Canada. Through this platform, we are able to support multi-jurisdictional research projects and data requests, and the platform contains an inventory of available data in different jurisdictions. And this is really able to create awareness amongst researchers so they can see the potential of linking intersectoral data. Another example is the Canadian Research Data Centre Network, which has a volume of linked data sets accessible to researchers. And it's a place to bring together, among other things, health and social data.
First, I want to thank our speakers for their time and for sharing their perspectives. In the research community, the importance of integrating health and intersectoral data is well known, but there are many barriers to operationalizing this. We've heard some real-world examples from our colleagues about these barriers, including data silos, legislative and cultural barriers, limited availability of resources, and a lack of common standards. Consistently, we see that partnerships have been essential to mitigating these challenges in the countries we have heard from today, by laying the groundwork for the identification of mutual priorities across sectors, by enabling learning across jurisdictions, and the opportunity to leverage these experiences and models of data access. In particular, international partnerships have served to inspire other countries to explore options to integrating these valuable data to understand populations as a whole. These partnership models may also help open the door to other enablers, such as senior championship and monetary or other resourcing support. In closing, we are sharing a slide with related sessions that may be of interest to you. We encourage you to explore them. Thank you for watching this on-demand session.